Now, and we are recording. Okay, so just very briefly, I'm just going to go over the fact that it took a long time for us to make this merger happen. June was instrumental in this and to getting this to happen. It's something that when I first started with this implant, and then I switched over to denser burrs, it kind of changed my practice, and I'll go through all of that with you guys now. So let's jump right in. So being blocked, here we go. So I want to call this the MegaVersah, right? Because it's the combination of Megagen and Versa together. And basically, it's been a long journey. Been traveling around this long journey of trying to get this marriage together. Because again, when I first started using the Versa along with Megagen together with the AnyRidge combined with the actual Densiber, which now is in a gold color, and then taking it that next step, that next level, to where we were going to bring together the R2 gate kit and the Versa C-guided kit together. So these are some of the things that you'll need to learn about, the fact that we're now combining these two processes together, because guided surgery is kind of the preferred methodology of surgery. So being able to partner these two together, both in the R2 gate software or in Blue Sky Bio software and wherever softwares that we really want to try to get this into. So kind of bringing it home now by putting these two implants together, because the key to success with the Densiburs is getting great primary stability, and there is no better implant on the market at attaining primary stability than the AnyRidge implant. So, but this is 5 years ago in IDS headquarters, when Nick Ellion's office, we actually did this surgery here in front of 40 extremely bored Benco sales reps. And they had no idea what implant surgery was, and I was supposed to show them what that was about. This is actually Kerry Lyon's brother, Stuart. And what was interesting about this case is I was drilling and I followed the instructions. First time I'm ever using the burrs. They did not pay me, no. No, they did. They paid me. It came 5 years later in the form of other ways than monetary value, and we basically accidentally discovered during this case that I was actually doing a sinus lift. I was just drilling bone. I was supposed to go 7 millimeters because I had 7 millimeters of bone, and then as I started doing the osteodensification drilling in reverse, instead of placing, what I was going to do was just break through the sinus floor and place an 8.5 millimeter implant. I ended up placing a 10 millimeter implant, and I had bone around the apex of the implant. But if you're watching, you're noticing how it's making a little hollow crest around that bone, right? And that's something probably Salah spoke to you about, having that little hollow of bone that forms around it. It's a rim of cortical bone that forms. It's all happening because we're auto-compacting the bone. And then when we go ahead and deliver an AnyRidge implant at the same time, we're going to get that wonderful stability. And because we're using the AnyRidge implant, we do not need to over torque this. This should go in by basically, you can see where it is right now, a millimeter short, just like we normally do. And then we can pick up the ratchet and just take it home, that final stretch. If we're ever in doubt of trouble, if we're too much pressure, we reverse it out and give it another turn or two back in, just to relieve the pressure. We got excellent ISQs on this. We placed the healing abutment the same day, did the usual methodology of what we normally do for our loading protocols. And I think you'll find that getting primary stability is now even easier than it was before. Not that it was that difficult with the AnyRidge, because we were able to just under drill and stick something in there, but I think that we'll get it even easier and not have to use let's say more narrower implants in a lot of these cases, or engage even the smaller core bodies. But 5 years later, on this case, going by the regular ISQ protocol 6 weeks later, we can see here on the middle x-ray over there, you can actually see that we're actually into the sinus, but we're engaged, but we actually push the sinus floor up just a little bit. We got an excellent ISQ value. I took a standard impression because I didn't have any digital technology 5 years ago. And I delivered a nice final crown. Here you can see the x-ray. And delivered a nice final crown 5 years later. And this is a 5-year radiograph of that same site. Now, I could have gone wider, which is something that I would do now. Back then, I had no incentive to go wider on the implants. It was only to get better stability with my thread design. Maybe you could argue that the AnyRidge 4.5 threads were a little bit better at handling lateral forces because they have wider threads. There's always an argument for that. Or the 5mm, for even better at holding those threads with the 3.3 core. But now we can change our focus differently. We'll talk about that in a little bit. But you can see 5 years later, implants still in the mouth. I still see Kerry Lyon's brother quite often. He's always breaking a tooth here and there. As you can see on the upper left, he's got 3 implants in a row. He's got them all over the mouth. So I'm keeping close eye on him in this case. So I started with this in 2000 and late 2014, and now we're 2020. And it's been getting better and better because we're learning what we can do with this implant and with this burr at the same time. We keep exploring and realizing there's a lot more to the AnyRidge implant than just the threads. I hated that ad that we had, it's all about the threads, because it was not all about the threads. It was all about the surface. It was all about the one singular connection. It was all about that connection in itself and how it withstood that lateral forces, so that we were able to get a good connection, that Magic 5. There's very few implants on the market that could compete with our connection. There's a handful of them that may be slightly better. Now the Bicons and the company Joel used to work for, that those companies, they maybe have a slight step in the advantage on that, but they can't compete in terms of implant stability. None of those implants can. This implant can do it all. They can do it. It can do it all. Yep. So you guys seen this video a million times, and I'm just going to show it again because it's showing how the thread design goes in. It engages the bone, and it talks about over here about stability. We lose that drop in ISQ value with a standard implant at the 1 week to 2 week level, and it starts to rise back up by the 3 to 4 week level. Why? Because we have that great surface texture, that calcium phosphate infused, calcium ion infused X-speed surface helps bring over more phosphate ions, helps the bonding, and helps us get to that secondary osseointegration level much faster than most other implants. So in my practice, I don't do a 4-week protocol because I'm always doing immediate implants. So I'll do a 6-week protocol. I'll bring them in at 6 weeks, I'll recheck them, and if I like what I see, I'm already starting to take impressions, even on immediate extraction cases. Most of the cases, I'm really waiting for the soft tissue to heal, not for the bone to heal, because my ISQ levels are already back up there. I know Eric doesn't really know a lot about ISQ, so we'll have to educate him about that. But now that we have the new beacon, thank you, Eric, for the new beacon. I think that thing has been incredible because there's no excuse. Oh, I don't want to bring it into the room. Or take the ISQs, see if it's ready. Let's use this implant to our advantage. And we'll talk about how we can do that together. Normal drilling protocol. Soft bone is D5. Dense bone is D1. D1 bone, we may drill all the way until we get to that implant diameter that we decide to go to. Whereas in soft bone, we may stop short. We may stop 1 drill short, 2 drill shorts, 3 drill shorts. Depends on what kind of bone density we have. We go in there and it's paper mache. We're probably taking a lance drill, maybe another pilot drill, and then we're already going to a wide diameter implant with extensive threads. That's where those threads come in very, very handy. And this is typical, AnyRidge loading standard drilling protocol that we've been doing for many, many years, right? There's nothing new. If anyone has any questions about this, stop me here, but it's nothing new. Under drill, and the less dense the bone is, the more you want to under drill and place that wide implant with those really aggressive fins. And that's how we've been treating things. So the wider diameter implant, we would go ahead and put into that softer bone. And essentially the idea was, if we do that, then by that same 4 or 6 week loading protocol, we were able to go ahead and load as if we were in dense bone. So if a patient comes in, they have lower anterior tooth, they're missing it, I could load the same day on that dense bone. I could wait 6 weeks and then load, which would be my normal protocol, unless I'm really being badgered to give a tooth. I always try to wait and just give them some time. But for the most part, that's where we were heading off. Now, if we had that D5 bone or D4 bone, or even D3 bone, we would do that same thing. Under drill, place that wider diameter implant, and then try to come back at that month and a half or so and retake our ISQ and see when we're going to go ahead and load the implant. So I show this all the time. You guys have probably seen this. Most of you have probably seen this. Is a 3.3 millimeter osteotomy, and just for traditional sake, we're going to place a 5.5 millimeter implant, and I'm going to keep increasing the torque. I'm starting out at 35. I want it to go down at 35, and then you'll see some skips in the video for a moment. That's me increasing the torque value, going from 35 to 45, then to 50, and then to 60 to get the implant to sit subcrestally. And this implant loves to live in the subcrestal zone. We know that. We want to keep that thread, that big wide thread, into that subcrestal zone. So we were able to do that by going into that soft bone, under drilling to the 3.3, placing a wide finned 5.5 millimeter implant. So now what can we do differently? Instead of doing the same old thing, and since we have some newer type designs, what can we do that can combine the two, between that denser burr and choosing the right dental implant, like the AnyRidge implant? So we did this study, and I think this will be great. I'll share this with you. It's accepted for publication by the International Journal of Oral Implantology. We had 5 doctors on this. Chuck Schumer was actually included with some implants on here as well, but he's not on the publication for some reason. But we did a 5-year follow-up of 253 implants with this osteodensification technique. And this is going to be coming out this year. So you'll get to see it more. But what we found, we did 57. You can see the second most implants were from me, which is 57 implants, right behind Zimmer, which was 62. And we did have one failure, and that's just going to happen because patient's going to get an infection, and I'm an aggressive doctor. I'm going to have one that's going to fail. It's out of 57 implants. I was surprised that I only had one that failed, because so many of my cases are ridge splitting, bone expansion, sinus lifting. And so having only the one that failed made me actually happy to do that. But a lot of these guys in this study, they didn't perform immediate implants. They were doing it on healed sites only. So we had that to include. All of our implants of those 57 were in the top range of 37 months and above, going all the way to the 65 months. So we were in the longevity wise. The NEOS people were in the early part. They didn't get to that part far along. And what they typically saw was a drop by that 3rd week and an increase on the 4th week in ISQ values, except for the AnyRidge implant. That implant was the only one that didn't change its ISQ value. That's not true, I'm sorry. The Zimmer also did not change its ISQ, but the Zimmer did not start out high on their ISQ value. They started out lower. We started out higher, and we kept our linear plateau of the ISQ, which we know that's why we love this implant, is because it does hold its ISQ for the entire time. So what we found was the bone instrumentation, utilizing the denser burr and the right implant selection, made the difference for the ISQs. It gave us both better initial torque values, which we had much higher because all my torque values were high. I had 60s and above, 50s and 60s and above, and all my ISQ values are very high. I would start out at high 70s, low 80s on immediate extraction cases. And that's something that the other companies can't do. Zimmer can't go ahead and say you'll get guaranteed mid 70s ISQs on your immediate extraction cases. They can't. They just can't get that type of values. So the key to the success for that was, or we believe to be, those knife edge threads. Now they didn't have to be super wide, because I am not a super wide thread guy. If you look at my inventory list for the years, I was buying very, very few of the 5 and the 5.5s until recently, when we came out with the new core bodies. Before they were FDA approved, I was smuggling them in. They fell off trucks, and I was able to, pick them up off these trucks in Brooklyn. And I was playing with the 4.0 and the 3.8 core body on the 4.5 because I do like to use those implants for molars. They're fabulous. So those knife edge threads, but the design of those knife edge threads, it's not that they're so wide, it's how they're designed, how they kind of spiral a little bit and grab that bone. The apical diameter of that implant works perfectly in harmony with the densa burrs because we're creating that little halo, even in the immediate extraction site at the apical region. So it's a really wonderful feature of that. So we didn't have really the decreases on the ISQ, and that changed our loaded protocols for basic implant placement, and using the denser burrs, we had even more success with that. So this is a slide from Joel. He gave me this from a while ago about on the aseptical motors, but these are my pictures. And just to go over, because some of you may or may not know what we consider dense bone and what we consider soft bone. So if you can see the top, you can see that D1 bone is very, very white. And if you look inside, not to the one on the left, but look on the one on the right, when you can look straight down into there and you see no bleeding whatsoever, that's D1 bone. We want to properly instrument those with the denser burr all the way, just like we would with the standard any ridge drills, right? But the difference is that now we're going to have even more compacted bone. So we have to be super, super careful to encourage some bleeding, to scrape inside the osteotomy. If necessary, take a little small drills and make little punctures, not buccolingually, but more mesial distally to engage into that cancellous bone, into that medullary bone, which invites more blood supply. So when I see no bleeding, I get scared for the any ridge, and I get scared for denser burrs. Doesn't matter what implant I'm using, because it's too dense. I don't need such a dense bone to place an any ridge. I'll go narrower, I'll go less threads. And that same mentality should be throughout all implants. The same thing about the D5 bone. If you look at the D4, D5 bone, it's a type of bone we can take a periodontal probe and just stick right through. It's like a sponge. That's where those magical threads work very nicely. But we can also use the denser burrs in those cases to get a perfect circle, which is wonderful, densify that bone, and not have to go super wide with a 5.5 implant. Because not every case, even a D5 bone, is going to allow the width of a 5.5 millimeter implant for us to engage and get that primary stability. So we have the 4.5, we can go with something like that with the 3.8 millimeter core. And especially in the posterior maxilla, which we'll talk about this in another webinar Scott wants to do, I would go with that S2 option for the abutment so that we can have strong connections and not have to worry about fractures. So Megagen's been talking about the color coding of bone for a long, long, long time. It's using this eye, that has a color spectrum to determine what is dense bone and what is soft bone. So having the R2 gate software, if we're using the R2 gate software, we'll have different contrasts between the two. You can see the blue would be totally non-equivalent bone is completely soft bone, and the yellower bone is going to be harder. Teeth will show up yellow, just like the outer cortical plate of bone will show up yellow. So we can examine these sites in advance, and it's important that you don't trust the doctors that they understand this fact, because they don't. They need you guys to explain to them half the time how to read a CBCT. Then really, we think that our biggest problem, we think we can trust the doctor, and we can't. And then we end up with problems later on. So having that CBCT, looking at that very carefully, determining what is that dense bone, that super dense bone, and it shows up super white on the cone beam. Yet if I ask the doctors to tell me what's dense and what's soft, they can't really tell me most of the time, and they want to go by Hounsfield's recommendations. So they'll take their mouse, they'll hover over the CBCT, and they'll look for the Hounsfield units. But guess what? Most of the companies are removing the Hounsfield units from their systems. If you go to CareStream, you need to get a pixelate update. If you go to Blue Sky Bio, they removed it and they hid it. Why? Because they don't want to be on the line. They don't want to be on the hook when something goes wrong. And they say, oh, well, you told me this is dense because I see here I have 800 Hounsfield. And according to some study I read by Peter Ma so long ago, when there was only a few cone beams and they were able to kind of standardize it more, you were able to look at it and say, oh, these grayscales are accurate and this is going to be dense bone. And he later on came out with another study saying not all grade levels are created equal between different machines. So we have to be very careful with that. So looking at with our eyes, looking at what's dense bone, what's soft bone, using that color coding system to evaluate that D1 bone, as you can see, is super, super yellow in the color coded spectrum, and D5 bone. That's why I'd encourage everyone of your customers to download that free software, the R2Gate software. It's free. There's no big deal with it. Now we can look at these and say, what should I be using denser burrs for? Can I use it in D1 bone? Yes, but how do I use it in D1 bone? Am I using it in D5 bone, D4 bone? Yes, absolutely, all the time. I actually don't even drill with any ridge drills anymore. I only use denser burrs in the soft bone. That's my protocol. It makes my life a lot easier and it gives me more predictability. So once we understand when we can use denser burrs, which is always in soft bone, and I'll show you how to use it in hard bone, but we need some tricks. But we have to understand what is osteodensification, which you had that presentation by Salah, by Dr. Huez. But basically, it's a very simple thing. We're talking about plastic. We want to make the bone plastic. It's not complicated. Low plastic deformation of hard tissue. I changed his terminology just a little bit because he has it of tissue. No, we want it of hard tissue, of hard bony tissue. But it's also low plastic. We don't want high plastic deformation. We don't want to turn into silly putty. We want that bone that was soft to become denser, more condensed, and at the same time preserve the mineral content that's inside of the bone itself. So you've probably seen this video. Did he show you this video? No comments? No? Okay, so this is an example of the denser burr inside of a gel. And you can see how it creates what we like to call a hydrodynamic compression wave. So we're using it in reverse. This is at 1200 RPM, and we get this cloud bubble that forms. This is staying inside like a tornado. It's sucking like a vortex, sucking all the water in. The only way that you can accomplish this is if you bounce the drill up and down because it needs to have water introduced into the osteotomy. The second you have this lapse in water, we become just like a standard drill. So having water is there to facilitate osteodensification. Without water, we're toast. So we turn up our machines to the highest level we can on water, and we make sure we tell the doctor, dribble it like a basketball. Go up and down, up and down. Let the tip of the burr get cool, and let it introduce that water into the osteotomy and create this hydrodynamic compression wave. When we look at this with a standard drill, the same thing, I'd shut off the volume, but you would hear the beep, beep, beep and going in for reverse. You can see we do not get that. We don't get that same compression wave. So this is what separates denser burrs from every other burr on the market. I've tried it even with the copycat burrs. They cannot make these clouds. It's not possible. We have several videos online about that, which I'm happy to share with you. There's a nice one done in Europe. It's escaping me who did it. I think Omid MegaVersah. Sorry, Omid. Yeah, Omid did it recently, and there's also one from even before that from Brazil. So they're showing how it necroses the bone. It does the opposite. But you will have trouble every time if you try to densify bone at 1200 RPM and it's dry. So you got to look at the doc and say, seriously, guys, I need water in there. We need to cool this thing down, and we got to create this compression wave. It's the only way that we can get by doing that. And that compression wave is going to come in very, very handy, and I'll show you in a moment.
Isaac,
so this, yeah.
If we were in a lunch and learn and we had our motor set up and we had a denser burr, we got a glass of water, would they be able to do that?
No, it needs to be gel. It needs to be gel because gel has collagen inside. So
Okay.
hair gel. You'd be able to do with hair gel.
No, I don't have any.
Or hand sanitizer. That we have tons. Because I don't have any hair gel either, so I feel your pain.
Are you?
Eric, I'm sure Eric has some gel.
Are you definitive, Ike, on the 1200? RPM?
No, no. You know, 1200 was the number that we advised from Versa as the advice. I've done it at 1,000. I'm very lazy. My first thing that I have on my motor is 1,000 RPM. If I'm going to use a Densibur and I just push the button on the floor to hit reverse and I'm in 1,000 RPM, you know, it really doesn't matter to me. It's just the faster the speed, the more chance of creating that compression wave. But how much do I need that compression wave? If I'm doing a sinus lift, yeah, maybe I might bump it up to 1,200, you know, push a couple of buttons. But I think it's definitely some play in there. And for the experienced reps that are out there that know have worked with this before, like Joel, you've been working with this for a while, you can see clinically what's going on and when and what you should actually change things with.
Yeah.
So, you know, if you're getting the same results, just go with it. Just go with it. You just want to have good success.
I just go a lot slower. I mean, I honestly, I go 600, quite honestly. So
You can do well. We'll show how that works with bone itself. We actually shut the water off and go to 200 and just push the bone around. But we'll talk about that in a little bit. This slide, it has a lot of words on it. You could read it all you want, but it's all about dribbling the basketball, applying load, removing load. We want the bone to kind of relax, and you can make anything bend. Anything in this world can have a bending point, just like metal. I like to steal this video. This is from The Matrix, and the guy is bending the spoon with his mind, right?
there is no spoon.
So there is no spoon. Exactly. That's the secret. So there is no bone. There is no bone. So we can bend the bone. We can make the bone bend to our will. We just have to know how to treat the bone to do that. So trying to get it in this plastic region, the green area here, you guys can see my mouse, right?
Yeah.
Yeah. Okay. So this green region is where we're trying to get it. So we can have elasticity based on the amount of collagen that's inside bone. So the more dense the bone, the less collagen is in there, right? The more hard minerals, the more hydroxyapatite and those type of things that are in there. So we have to think soft bone is going to be easier to bend, right? Now we can make that hard bone bend. We just have to do some tricks to it. But that elastic region is going to be dependent upon how much collagen is there. To plasticize that bone, to get it to become plastic, is the point that we're trying to achieve before we get to this area of fracture. Because once we get to this area of fracture, we end up with this crack in the bone. And then we might as well just take osteotomes or rotary instruments that we were using from the past. So we want to avoid fracture, keep everything in that plastic region by choosing the right cases with the right amount of collagen, so the softer bone, D3, D4, D5, and telling the doc, bounce the ball, bounce the drill, and allow a lot of water.
Isaac, why do you call it plastic region?
Plastic, because plastic is bendable, right?
Okay.
So if you take plastic, it can be very hard, but we can all bend it, right? But once we get to a certain point, we bend it, it cracks. And now if I have a plastic stick and, you know, I just want to bend it a little bit, I can bend it. Once I get too far, it snaps, it cracks, game over.
Okay.
So that's why we want to get that plastic type of region. We want to make it softer so that we don't have to do so much grafting. Or I shouldn't say we don't have to do so much grafting. We don't have to rely on the grafting as much as we did beforehand. So where we used to say that we needed wider implants and softer bone, we don't necessarily have to say that anymore. The threads are not as necessary. So this is not to say that we shouldn't use the wider implant, but maybe we don't necessarily need the wider threads. Because even in that soft bone, I would rather have that implant with the wider core body, let's say a 5 with a 4 core, okay, maybe not the 4.3, but a 4 core, so that I can get less issues with getting that implant in, number one. And if I also get more strength resistance compared to the 3.3. I have less chances of fracturing an implant if I have a 4 millimeter core as opposed to a 3.3. I can count on my hand how many fractures I've had with the AnyRidge implant, but we do see them, right? So the worst cases is when we see them and it's a 5.5 millimeter implant. We got to get that sucker out. That's not an easy task. So
but
we want to.
But from a confidence perspective, guys, we all need to know, even though the threads look smaller than they are in the pictures, you can clearly see, you still get that AnyRidge bite in the bone, no matter if it's a smaller thread.
That's the truth. So even in the under drilling cases that I've done, I found it to be the same. I think it's more about the surface texture and the design of the implant. We still have that same apex, so we're still getting
Right.
that. So I think we're overdoing it with the 5.5s, let's say, in 95% of the cases. There's still those
Right.
cases that you want that 5.5 with the 3.3 millimeter core. But I've switched all my stuff over. I've been buying the 4s and the 4.3 cores and even the 4.8 cores for a lot of the cases. So that's been my protocol. I've been using it for a while, and now I really don't have to have that fear, because that second molar implant that Dr. Park always talks about, that's the one that comes back to bite you. It has the highest failure rate. So if I'm using a wide core body and I'm using an S2 abutment, and how am I going to break that thing? You know, you really have to come at me with a baseball bat to break that. And these days, that's not so far-fetched. It does happen, right?
I think you make a
So,
good point. I think you make a good point in the sense that if you look at that chart, it can become overwhelming and confusing, saying, what the hell do I use? You take a look at so I think that's where it's important that we understand what it can do in the S2 abutment and the wider core. That's really, really important, because it confuses the heck out of some of our doctors. They just don't know what to use.
so the way I like to say it, if I was going to sell it, the way I'd like to say it is, you're able to customize the implant based on the patient, where this has never been done in the history of implant dentistry.
Right.
Unless we're going to go ahead and CAD/CAM mill out a tooth, mill out an implant designed for the patient. This is the first of its kind where we can choose not only the thread design, the core body, and yet with all this craziness, with all this amount of material, you still only have to choose for one connection size. So all your parts and pieces are still the same. Maybe you're getting back a different abutment, but other than
Well,
that, peace of mind that you can choose the right implant and not have to have this a crazy amount of inventory.
that's significant. That statement is significant in the sense that everyone's always talking about customizing the prosthetics.
Yep.
But now we're partnering the customization of the prosthetics with the customization of the implant.
Of the implant.
Yep.
Right.
It's great.
Exactly right. So different things that we can use this for. So when we're talking about that D1 bone, that really dense bone, it doesn't mean that we can't use densibers. We've been using the AnyRidge, which is an extremely aggressive implant compared to most on the market. And we've been using it for ridge splitting, and we found out this is the best implant in the world for ridge splitting. It's the best implant in the world for expansion, because we can use the implant to help us expand. So it's been great for that. Immediate placement, I mean, we could talk about that all day, but we all know the deal. Sinus augmentation, that's going to be a key factor. Standard reverse drilling. And then the last one is being blocked by my screen, but I believe it says guided surgery. So I'm going to talk to you about how to do that. All right, so first we'll talk about ridge splitting. So to understand the basic principles of ridge splitting, I always like to point to the louvre. The louvre is made in a perfect triangle, and then there's a triangle within the triangle. So if you look at that outer triangle, that to me is going to represent a more cortical outer layer of bone. Then that inner triangle is going to represent that medullary bone, that softer bone that's on the inside. Now, even if we don't have that softer bone, we can still do this technique, but we're going to need a very experienced doctor that's done a lot of these ridge splitting cases. So when we look for these types of cases, we want to try to pick a case where we can see that it has some of that medullary bone inside that we can split down the middle. And in my opinion, and there are people in the world like Howie Gluckman and Radshaw Djordjevic and Sinjana Paul and all that can violate the rules I'm going to tell you. But if you want to stay in the safety zone, when we're talking about ridge splitting, we can ridge split as wide as the base. So however wide our base is, that's as wide as we can expand the crest. So if we have 8 millimeters at the base and we have 4 millimeters at the top, then we can expand out to 8 millimeters. Can we get beyond that? Yeah, there's the people that can. But for the most of us fall in that middle range where we need some rules to have success. We're not kind of superheroes. And for us, we need to stay within that base. So try to pick these cases where the base is already wide, not these super thin, narrow little cases that come in and say, oh, let me open it up like that. like a flower. It's going to be harder for you to have success. So some of the other rules, you want good, healthy patient. You want to make sure that they can turn over bone. So when you're dealing with these cases, I always like to get some blood work done to make sure they have good vitamin D, good folic acid, their body's able to heal. I'll ask the patient, have you ever broken your arm? How long ago? Did you break any part of your body? How long ago? How did you recover? How was your last surgery? A lot of our patients that are coming to us for implants, they've had plastic surgery. How did they heal? Were they good? Were they bad? Those are the type of patients that we can definitely treat for rich splitting. And the main factor that's going to be is how much cancellous bone is in between in that region. So where is our blood supply going to come from for us to have survival during this technique? Because a lot of these techniques, they'll go with just straight cortical bone, but there's no blood anywhere. So the bone just dies out. So we have to look out for that. So previously we were using the expanding tools, and then we'd use a mallet. And what's nice about the denser burrs are we will not have to use a mallet. We don't have to subject our patients to mallets and hammers, because if you live in a city like New York, you come at them with a hammer, they come back at you with a gun. So we got to be a little bit careful. And I know that's the same way how it is down in the deep south, right? So you got to be careful of the guns. So we want to look out for that. Try to pick these cases with these nice centered ridge crests. Like I have a case here that has very nice centered ridge crest. So I'm not looking at a right triangle. I'm looking more at an isosceles triangle, and I'm opening up the triangle. Those are cases that are slam dunks. Can you do the right triangle? Absolutely, you can do the right triangle, and you can open it up. But that's where the doctor has to have some skill, because once they're using the burrs and they go in with the implant, they have to redirect the implant into the correct position to make it come out the center. Does that make sense? Because otherwise we're going to have a severely angulated case where we're going to have to use custom abutments. Whenever we can avoid using custom abutments, we avoid headaches and we avoid problems. So those right triangle type of cases, they just, as the implant is going in at that last moment, you want to bring it back over and put it in the correct position. You're expanding that bone. So the centered cases, these ones where the crest is in the middle, those are easiest to just pop open and open up and place in the implant. So again, this plastic region is what we're trying to accomplish. So how am I going to get that dense bone to become plastic? Well, I'm not going to be able to do it with the burrs themselves, because the burrs are already densifying dense bone. So you don't want to densify dense bone. So how are we going to do that? How are we going to get that plastic region? We're going to open a flap, and we're going to take out our piezo instrument. When we use this in conjunction with the piezo surgery units, whichever one they're using, then we're going to be able to create some pressure relief. Just some little tidbits, I always like to throw in how to stretch the muscles here. You see we're stretching the mylohyoid muscle, so I get easy closure when I'm done, because I'm going to have to do some grafting. With these cases, doctors like to say, oh, I don't need to graft in these cases. No, it's bullshit. You need to graft with these cases. You have 2 millimeters of bone at the crest. You're going to need to graft, unless you're going to flatten it down and place implants, which in this case, if I do that, I need short implants because the nerve is there. If I want to place 10 millimeter implants, I'm going to have to make a nice cut. When you're making these cuts, we want the piezo to swing like a pendulum, back and forth very, very freely. Now that's going to relieve any bony tags between the two cortical plates. Once we have tamed our depth, let's say we're drilling 10 millimeters, we can then pick up the denser burrs. You can use a pilot drill first if you'd like to score it, but just score it at the top, like a lance drill. And same with the denser burrs. Initially, I just scored at the top just to find my markings, make sure I'm happy with my placement. Then I start to go wider with the denser burr. I already have a 10 millimeter cut with my piezo instrument. Doctors sometimes will say, oh, I only want to cut it 4 millimeters. No. Cut it all the way down to the base, then use the denser burr in a pumping motion. And this one I'm using probably only about 800 RPM. I was scared to go to 1200, but I'm going a little bit slower. Might even be 600, Joel. I'm not certain. But I'm going up and down and bouncing it and allowing water to get in there to try to expand it. And you'll see after using several burrs, I can widen it out all the way. I'm using already up to the 3.545.
Let me stop you right there, Ike, because obviously we're going to be when we're going out in offices and stuff, we're going to be teaching that. slight little protocol. So as I heard you call it one time, you call it the 1-2-3 protocol. So you go 1-2-3 pressure and then off, and then 1-2-3 pressure and then off. So that way
Exactly
that
right.
in there. So that's really key, guys, for you to pick that up. 1-2-3 off. 1-2-3 off. Okay.
Yeah, I abandoned that. I don't know why. I don't know why I don't say that anymore. That's exactly right. It's 3 seconds of pressure and you're on. So you're getting in there and you're getting out. Up and
Right.
down, up and down. And I went to the basketball term, but I like that better because it gives you a rhythm. Gives you a rhythm that you're constantly in, so the doctor can say it in their heads.
Right.
So it does make sense to do it that way. I like that. I'm going to go back to that.
There you go.
So you can see now I have 4 specifically designed spots for my implant. Now I place the AnyRidge. I got 4mm implants. I'm going to splint these together, so I'm not worried about the size. But look how the bone widens now. Why? Because we're using the AnyRidge implant. Now, once I see the implant starting to bind too tight, I stop. I don't try to get the implants all the way subcrestal yet. I want to use my implants to help expand. Look how that middle implant over there is sitting high up into the bone. So then I'll slowly take it down one by one. I'll go back and forth to help expand the bone so that I'm not putting too much pressure in one spot.
Right.
Does that make sense? So now you can see I'm in subcrestal placement. I'll take my ISQs, so this way Eric will be happy. And then we'll go ahead and we'll put some graft. I'll skip the ISQs, but actually I shouldn't. Look at the high ISQ rates. They're very, very high. They're tremendous. Ridge splitting, you'll get great ISQs because we're in that cortical plates. I'll put my bone graft in at the same time, and I'll graft because I'm expecting some anger from the bone. You're going to get a response. We're having a fracture, so there's going to be some remodeling. So if I can stunt the remodeling too much, I won't get a lot of bone loss. By placing the bone graft, placing the PRF material or membrane, whatever they want to use, and suturing up properly and obtaining primary closure in these cases. Some people like to put healing abutments on at the same time to help tent it up. I've been doing that more recently. I've been having excellent success with it. That's fine. Just make sure that they're using new, fresh healing abutments, not pre-sterilized abutments, unless they have the Meg Cleaner. Maybe then they can go ahead. That Meg Cleaner does work quite nicely. So you can see same thing on the other side. I did the same exact thing. You can see how we placed it in nicely, good primary closure. And this technique, what I like to call it the sandwich technique, because it's very similar to what Humlei Wang was discussing when he did the sandwich technique. He took a layer of autogenous bone over exposed threads of the implant and then placed another material like a xenograft. That doesn't have to be xenograft to me. It could be allograft. But when we're doing ridge splitting, we have that same wall covering now. Instead of scraping autogenous bone, we actually have autogenous bone covering, and then we can put bone graft right over the top of that. Some people do like to decorticate that bone. I don't find that it's necessary because we already split the bone and access the medullary bone, so the bone is bleeding, it'll feed the graft. I do like to scrape up the bone a little bit, so it's not like a marble slab. So I will scrape the bone a little bit. So get off like an outer layer, just really quickly with like a back action chisel. Just scrape it so it's not so shiny, dense bone, and allows the bone graft to sit nicely on top of it.
I
So
think
12 weeks. Go ahead.
Will the minimum buccal lingual width change at all compared to using a Versa bar versus a traditional bar with ridge splitting?
So it hasn't changed for me, but now I'm able to go with wider implants. Whereas before I might have stopped at 3.5. Now I'm going to a 4.0.
Okay.
I was so scared that I'm about to break the bone, which I did with the rotary expanders. Megagen rotary expanders are excellent. They really are. They're very well designed. They're easy to use. You can pop in and out, back and forth between each other. It just takes a little bit long. So with this, it's the same ideology, but we get to do this in a faster pace. So we can go site to site to site instead of going with an expander. And you really need more than one expander. You need to use one expander, go put in the next one, and then go back to the other one, make it wider, and kind of sequentially keep increasing them. With the denser burrs, you don't do that. You just take one drill, let's say 3 spots. Second drill 3 spots. Third drill 3 spots. Fourth drill 3 spots, and then you place your implant. So it's a much faster process of doing this. I wouldn't say that it's better other than the fact that I do find that now I am placing wider implants than I was previously.
How about your
So-
healing period?
So for this, I waited 12 weeks with the graft, but it all depends on what my ostel was the day of. So if my ostel was good, then I would come back, and how much bone graft did I put? That's the other thing. I don't want to go in too early. If I'm going to have to do a connective tissue graft or a free gingival graft, I don't want to go in too early and peel the bone off of that area, right? Because then I just wasted my bone graft. So if I had a large amount of grafting, I might wait longer. So some cases might be 6 months, whereas a case like this where I was nice sound bone and I didn't have to do any grafting, I waited only 12 weeks. So that's going to be dependent more about the soft tissue. Okay, so if we need to do soft tissue grafting, wait longer for the bone to adhere to the bone, the graft to adhere to the bone. If not, and you're not relying on soft tissue grafting, you're just opening up a split and finding the implants, putting healing caps, then you can go in earlier. You can go in 12 weeks, no problem.
Quick question.
Yes, sir. Yeah.
If you're getting a reading on your ostel buccal lingual, when you do a ridge split technique like this, is it going to be different lower when you're doing the mesial distal reading?
I haven't. It's funny. You would think so, but I haven't gotten much lower. I'd get maybe a few points lower. I'm not getting 50s. So if I'm getting, let's say, 78, then the other one might be 72. But yes, it will be lower because there's less bone implant contact.
Wow.
Right? Everyone should understand the principles of ISQ, meaning how much bone is it actually in contact with the implant. So if I'm coming from the buccal, it measures the buccal and lingual together. And if I'm measuring the mesial, then I'm measuring the mesial and distal together. So I'm going to get slightly lower readings when I'm missing bone.
Right.
But with the AnyRidge, even with a little bit of bone, we still get high readings because the threads engage so nicely into that bone. Those knife edge threads and those little valleys inside engage that bone. And so you end up with good readings, better readings than you normally would. I'm sorry, I got to quickly give my son a game here.
No, it's books.
Oh, it's schoolwork? Okay, here. I don't know your password. Good luck. Talk to mommy. Okay. So in this case, I went 12 weeks. Also on the top, this is a great case to show because the bone is super soft. Plus, there's a sinus involved there, right? You can see on the upper left there, I have about maybe 5-6 millimeters worth of height. So I'm going to need to do some sinus lifting, same time. So same deal. I'm going to drill and place a 4 millimeter implant into 4 millimeters width of bone. And you'll see the bone will expand a little bit. It's going to crack there because I didn't go all the way to that next burr. I should have went to length. I didn't listen to Salah back then, but look how much expansion you can get by going through that. So we can go from 4 millimeters to placing 4 millimeter implants in, plus the implants are still in sound bone. So what I would have done differently in this case with that the first implant and the back implant, no problem. But the middle implant, I would have went a little bit wider with the burrs. Don't be afraid to go a little bit wider to get to that site. So if it's 4 millimeters, you can go the 4 millimeter burr. It's not good. You go to 3, 5, 4, 5 and place an implant. You don't have to shy away from it. Whereas, in the past, we're always thinking under drill. So at the same point in time, because I'm doing this same technique, I'm going to do that sandwich technique. I'm housed by bone, and I'm going to do some bone grafting with a membrane, and I'm going to get that bone. So I come back to the sites. You can see the lower right and the lower left, both tremendous amount of bone growth after I go back in at 12 weeks. My bone is healed. And on the upper left, look how much bone is on the upper left. I mean, that's, like we like to say, an orgy of bone. It's just a tremendous amount of bone. I get very excited when I go back in and see that. So healed very nicely. All was done around the same time. I think I waited like a week apart or something, maybe 10 days apart between the surgeries, and did I did the lowers together, and then I think I ran out of time to do the upper left. So you can come back. You can see my ISQs extremely, extremely high. They went up, and we love to see that. So we went from mid 70s and low 80s to all straight across 80s plus. So you get that. You got your doctor sold. If you can do a case like this, you got the doctor sold on the burrs. I mean, think about how much we spend on rotary expanders, sinus lifting instruments, all that, all done with one kit. We'll talk more about the sinus. This is not the whole thing about the sinus. It was just a quick one. So let's talk more about that. But before I get to the sinus, were there any questions about ridge splitting before I move on? No? Okay, great. So before I talk about the sinus, I want to talk a little bit about immediate implant placement. The AnyRidge is fabulous. The main thing that it did for me, that have really changed my practice, is taking a simple procedure of extraction and socket preservation and turning it into probably the most profitable thing that I do, which is immediate extraction, bone grafting, and implant placement, and second staging my implant the same day. So I have a 1 hour surgery that would have taken me, 45 minutes if I did an extraction and a graft. That's what I used to book. Now I book an extra 15 minutes, and I put an additional $1,850 onto that procedure. I charge $650 for an extraction. I charge $600 for a graft. I charge $1,850 for an implant. It's a very profitable procedure when I can do that all in one shot. Whereas if I'm charging, $650 and $600, it's only $1,250 for that same amount of time minus 15 minutes. It doesn't equate. That extra 15 minutes gives me that extra time to place that implant, and then you can do that with the denser burrs very, very predictably. We can do it with the AnyRidge very, very, very predictably. And now with the denser burrs, we can do it even better by keeping the implant in sound bone at all time without having to use the aggressive threads. So we can take a site like this where you can see I made a very narrow pilot hole drill, and then I expand it. You can see that crest that forms, and you can actually see on the left side, my mouse all of a sudden is not working, but on the second picture to the first picture on the right-hand side of the screen, you'll see that you can actually see the sinus on this case. I didn't have to put any sinus grafting material in there, but I just lifted the sinus. Now, if you really want to be, if you're a money-hungry practice, or if you're an insurance practice and you have to charge for each procedure, I would charge for that. You just did a compaction autograft. Why not charge for the sinus lift? Because you can see the sinus, you've accessed it, and you're placing the implant at the same time. You're just auto-compacting it using the patient's own bone. So you can charge for as an indirect sinus lift.
Isaac, did you use the initial Versa drill before you did the extraction?
I did. This is when this one I think that was already the gold burrs. So I like their pilot burr now. I used to hate their pilot burr. It was terrible.
So you did the same thing. You semi-sected the tooth, then you did the first drill, then you removed the teeth.
Oh yeah. Well, sometimes, so it depends on what I'm doing, but a lot of times I will cut the tooth into pieces. So I can use I like to call that the Sherpa technique. It's basically guiding your drill. So just like you'd have a tour guide carrying you up Nepal on going up Everest, same thing. If you like the position of the septum of the bone, then instead of extracting the tooth, you can cut the tooth into 3 separate pieces. If it's a maxillary tooth, if it's a mandibular tooth, cut it in 2, and take your first drill and drill through the root, and then expand that septum. It's a lot easier for doctors that don't have that dexterity. If you see a doctor that's like kind of a little fumbly, then let them do it that way. Drill the tooth, break it up into pieces, and if the septum's in a good spot, then you can start puncturing right in between the two. So that's going to mean cutting off the crown of the tooth and then sectioning the tooth, right? We can't just drill right through. We need to cut it down, get to the root base. Sometimes we flatten down the tooth all the way. And then once you section them, and I always section all my molars, always, because it just makes it so much easier to get out, unless it's a very, very mobile tooth. There's no headaches and there's no breaking of roots. And I place the implants in, I put the bone graft around, you can see the beautiful healing you're going to get by putting that in. So immediate extractions are absolutely fantastic in the molar region. You can see we bumped the sinus a little bit. And we can do the same thing on the lower, same thing. You can cut the tooth in half, but you can see that septum, and you can see the denser burr in the septum, and you can see how it expands it where we place the implant completely in sound bone. So again, we're not relying on graft for this site to heal. We're relying on the patient to turn over their own bone, which is in that 4 to 6 weeks. It's like drilling a standard straight osteotomy because I'm completely surrounded by bone, by the patient's host bone. If I have to go in and place bone graft and then come back, and if I come back too early, my drill slips into one of the roots. Typical thing that happens because that graft is the path of least resistance. But when I'm doing it the same day, I can place it into that septum by not cutting out the roots, like Scott was mentioning, or if I have a really fine hand, just drill into the septum, expand the septum, place the implant. It's really a home run. Now, 6 weeks later, I come back, I take my ISQ, and I go ahead and I load my implant. And I get a nice, beautiful result. And I'm loading it with a super wide healing abutment, right? That's the beauty of the AnyRidge. We have these 7, 8, and 10 millimeter healing abutments. They work wonders at shaping the tissue. So I don't end up with a lot of that slumping of tissue. Here's a case that I like to show a lot because it shows how to use it together. I can do it with partial extraction therapy, in this case using the root membrane technique. But if you look at the back implant, you can see that was an implant that I placed, and I didn't do any socket shielding, root membrane, partial extraction therapy technique on it. And you can see how the tissue slumps. So on this case, I was going to change it up, mix it up a little bit. I look at the CBCT and I can see the CBCT is very narrow. The tooth is occupying most of the bone. There's not a lot of a buccal plate. You can actually see there's like a little dip over there where the mouse is, in that area where I'm highlighting with that finger. So that's an area where I'm going to expect to get bone resorption, even if I graft. Unless I open up the gum tissue, the gingiva, and I make a big graft, an overgraft, and put a collagen membrane, which now became a very, extensive procedure, I'd rather try to save the roots. So in this case, that's what we did. We ended up cutting off the crown, and this will show you how to drill between the roots. But you can see we're sectioning the roots here. And then we're planning with the osteotomy, the osteotomies, we're shaping the roots for the partial extraction therapy or the root membrane technique. And then I start to take out my roots. So I've already planned one osteotomy. Now I'm using the lance drill to drill into that septum. Then I go with the densiburs in reverse and I pump, right, Joel? 1, 2, 3 out, 1, 2, 3 out. And I'll do that with all successive drills so I can take an osteotomy like this. You can see what's left over here is the pieces of the roots of the teeth, right? That's the partial extraction therapy. And I continue with my expansion, keep going. So I can do this in conjunction. This is, to me, is a award-winning procedure. You're keeping the soft tissue, you're keeping the bone, you're placing the implant completely into sound bone, into completely housed into sound bone. It's a 4.5 millimeter implant. And you can see I'm getting good ostel numbers, mid-70s. I put some Nova bone. That's what I like to use for partial extraction therapy because it squeezes in very nicely and fills in all those voids. But you can use whatever you want, whatever the doctor chooses. And then I use some PRF and a super wide healing abutment, and I'm very happy with how the soft tissue heals. Now look at that soft tissue. You see the day it leaves, look at the day it comes back. I have an 804 healing abutment in there. Look at how monstrous and voluptuous that tissue looks. So that's what it's going to look like on the x-ray as it's healing. And then go ahead, I'm taking my intraoral scan. I'm using a 3-shape here. I've been playing a lot with the R2 iOS lately. I've been really liking the scanner itself. And you can see I go ahead and place my screw retained crown. I've got everything in the right position and everything's healing quite nicely with that implant. If I look at that on the CBCT, I can take a careful look. I mean, the implant's occupying almost the whole space. I should get resorption of tissue, right? Because I would be impinging upon that 2 millimeters of bone space that I'm supposed to leave. But because I did the partial extraction therapy, I don't have to deal with that headache. I keep all that soft tissue. So when I look at that from the coronal view, I can take a look and compare my final implant crown as opposed to my other implant that I created. And you can see the difference between the two. So you're able to incorporate this for immediate implants, and you're able to incorporate it for any type of partial extraction therapy techniques. It works wonders, really a game changer for that. I don't know what's going to be in the long term with the immediate placement, but I certainly know what's going to happen with the soft tissue around the partial extraction therapy case. It looks like it's ready for war. It's going to be able to withstand all those popcorn eating, spicy foods, whatever can sneak into that gingiva. It's going to be able to withstand it. So let's talk a little bit about sinus augmentation. So there's 4 common classes of presentations of how we treat, and we know these from Dr. Park. Dr. Park has his slides of how he likes to treat them. He has the class 1, where we have this short but wide area, and he likes to place short implants in there. And even if you can see in this x-ray in the middle implant, that he just bursts right through the sinus, which is why initially Dr. Park wasn't really sold on the densibers. He'd say, I'll just pop through the sinus. But in this country, you pop through the sinus and something doesn't work well, you get a phone call from the lawyer, and then all of a sudden you have a very, very different case than you do in Korea. The class 2, we go with the mica kit. I really like the mica kit, but I'm really happy that I don't have to use it like I used to. I might have a case or 2 a year, but it's not very often that I would really encounter it. And sometimes I like the instruments from the mica kit if I do encounter a case of using densibers, where I did hit the sinus and I want to manipulate it. And then lastly, we have those lateral approaches. You guys know I teach sinus courses all the time. I have not done lateral sinus lifts for the purpose of lateral sinus lifts at the same rate that I used to. I would do, let's say, 50 to 100 a year on average. I'm below 10. And the 10 that I'm doing, it's usually because I got to take something out from the sinus. So this is Dr. Park's video showing a short implant going into place. And of course, for those of you who don't know how to use the mica instruments, this is the mica using the sinus express burrs, popping through the sinus. And this is very similar to how we use the densibers. We pop through the sinus, and I'll explain how. But we pop through the sinus, then we use a series of instruments. I'll speed that up a little bit. We use a series of instruments and pack in bone and place the implant in place. Okay, so that's typical for how we do it. And then, of course, the lateral approach. Lateral approach, there's many, many different ways. Doctors will say, well, I don't need densibers, I got a piezo. Well, guess what? Your procedure is cut in 1/4 amount of time if you're not using a piezo. They may like different burrs, like different tips from the piezo. I like to use when I was doing the piezo with the saw tip. So they may like that. They may like the Mila kit, which I think is a great kit, but not very hard to necessarily fit all these types of cases because the bone is not always curved the same way. And sometimes the bone is very thick and we can't even get the Mila kit in its place. So a lot of times people like to use these burrs like the DAS burrs. We used to have them as well. I think they made a comeback again to accessing the sinus, our diamond kit that we used to have. So I think we started to include them again on that newer kit that we came out with. That's a combo kit. Don't quote me on that, but you can check. But that's another way to access the lateral approach. But the good news for me is I'm really not doing a lot of lateral approaches. Almost all of these cases that I just showed you, the short implant, I kind of abandoned that. I'm placing longer implants and I'm auto-compacting. The lateral lifts and the crestal lifts and all that, I've done now by treating it with densibers for pretty much all of my cases. The exceptions are cases like this, where I have a massive cyst in the sinus. I know it's a little gory, but I have a nice, pyrocele that I'm extracting out, or I have a tooth in the sinus that I'm trying to extract out. That can happen, or I'm taking an implant out of a sinus. Those are most of my lateral cases these days. Here's an implant coming out of a sinus that somebody dropped in. So how am I doing these? Well, this is a case that was done by a general oral surgeon in Brooklyn, New York. This is one of his buddies, and he took out this tooth and he didn't put any graft in. 6 weeks later, his friend starts bugging him. He wants to get his implants done. He said, he's harassing me. I can't really get him in. He wants to get started. Do you think you can do those densibers he told me about? I said, sure. Send him in. I look at it. I see that I don't have a tremendous amount of room before the sinus. I take a CBCT. I'm looking at very, very low density. It's almost all black. If I look at the sinus and I look at the bone, it looks the same to me. So I'm thinking this is a great case to densify the bone. Right? You can look here, you can see if I plan an implant, it's not going to be a great site for a 10 millimeter implant. I'm going to need to do something to elevate that membrane. So by taking this technique that we showed you of using the hydrodynamic effect and flipping it upside down, we can elevate the sinus. So we open it up, we see the bone is mishmash, poor bone, and we're going to start using our densivers. So very simply, I start out with the first drill 1 millimeter short of the sinus. I may go to the second drill as well, 1 millimeter short of the sinus. After that, I go 1 millimeter past the sinus floor. So if I have a 4 millimeter sinus floor, I drill to 3 millimeters with the first couple drills. Then by the third drill, I'm already drilling 1 millimeter past the sinus floor. And the maximum that I should pass the sinus with the wide burrs, always go wide, wide, wide burrs, at least the 3, 5, 4, 5, but the maximum that we can pass the sinus is 3 millimeters. You don't need to pass the sinus more than the 1 millimeter, but if you want to autograft alone and push just the native host bone up, the maximum that you can lift is 3 millimeters. But if I introduce bone in, I'll just keep going 1 millimeter past the sinus floor. So if I have 4 millimeters of bone, I drill to 5, I put in bone, and then I use the densiburs and I stay at 5. I add more bone and then I stay at 5. I add more bone and I stay at 5. And we just keep doing that until we filled up enough of the sinus that'll allow us to push the bone up. So originally we were doing this at higher speeds with water. Now we took it down to the recommended speed is 200 RPM with no water. We don't need to use any water. We're just allowing the bone to go up and pack in. And this will be able to create as much of a sinus lift as we would get with a lateral approach. So you can see this soft bone. This is really, really super soft bone. It's not very pretty looking, but look how much we lifted from initially towards mid-treatment. So mid-treatment check, I now have at least 10 millimeters of bone. So I'm going to go ahead and place an implant. I should have chosen any ridge implant here. I chose any one. I used to choose any one in the sinus because I was afraid the cutback of the any-ridge would be too much and that the implant might fall into the sinus. So early on with the mica kits where I didn't compact that bone, I would use the any one implant. So this was just old hat for me to keep using the any one. You do not need to do that. If you have 2-3 millimeters of bone, the any ridge grabs like you cannot believe, and you have compaction in the sinus. So you're pushing this bone up, not like when we were filling the bone with the mica kit. So you do not have to worry about it. You can use the any ridge in 99% of these cases. So by having the any one instead of any ridge, I ended up getting slightly lower ISQs. So instead of loading the implant with healing abutments the same day, I ended up burying them because I had lower ISQs. You'll see now I'm getting 65, and it's not terribly low. It's not like 50s and 40s. I think I got a next one, you'll see like a 57 or a 61. For me, that's low. I'm used to high numbers from any ridge. So I like to use the any ridge for these cases. You'll get higher readings and you'll heal faster. And you can see this bone looks really terrible. So we ended up putting a little graft on. But you can look at that sinus and look how much we lifted. Sorry, I didn't mean to go so fast. But look at the sinus and look how much we lifted. And it's a tremendous amount of lift. Something that I would have had to either use an osteotome for, or I would have had to done with a mica kit. I wouldn't have to go in laterally because I have such wide bone. It would be a waste of time. Yes,
So Isaac,
Scott.
so you had 5 millimeters of vertical height. You drilled to 5, you packed bone, you drilled to 5 again. You packed bone, you drilled to 5. How many times do you do that to get that?
How much bone do you want to put? So the question is, how much of a hero do you want to be? Because right now, I can tell you that if I can lift the bone about 10 to 12 millimeters easily. So all depending on the flexibility of the membrane. So
Okay.
to be on the safe side, for a doctor that's just starting out, they wouldn't want to do that. So the first case that I would do is pick like a 7mm case and say, hey doc, why don't you try putting a 10mm implant in
Okay.
into this 7mm case? Don't add any bone. Watch the magic fly, because we can go up to 3mm past. Once they see that, they're going to want to take a 4 or 5mm case. And then you tell them, okay, doc, you can place that. You can double it up. You can place that 10mm implant. You're going to need to put about between a half cc to a cc of bone for, let's say, 2 implants. For 1 implant, about a half cc maximum, maybe 0.25 to half cc, when you can place that amount. Does that make sense?
Yeah, it makes sense. Now, do you typically use like a 10mm length implant for your lifts?
Yeah, I mean, I'll place longer. Now I'm placing like 13s into the same spot because I want to be a hero. I'm trying to show these massive cases. And I'll show you a little trick that I learned that really helps this fly. It's on the next case. So just very quickly, because it's bad bone, I'm going to put some graft and I'm going to put a membrane, and I'm going to come back at 6 weeks, right? 6 weeks protocol, even for the NE1. And look at my numbers, Eric. You got to be happy with this. 74. Oh, what happened to the rest of them? I don't know where they went. Oh, it's on the other side. It's being blocked. Okay. You see both numbers, right? So we have good, much higher ISQs. We were in the 60s. Now we're in the 70s. We're very happy. I always show, by the way, my lowest ISQ number. Because I can't show so many pictures and make it too confusing, I just pick the lowest one. When I record my highest and lowest. I don't record all 4, but now since I've been using the Connect, I do record all 4. I'm getting all 4 zones. But I want the highest and lowest so I can know what my range is. Okay. So you can see on the sinus, we've lifted the sinus completely. This is not like a little bubble shape like we would get from an osteotome lift. This is a unilateral lift going all the way to the medial wall of the sinus when we use this. Because that hydrodynamic compression wave, it ends up filling. And you can see how it establishes a brand new sinus floor. So we get beautiful soft tissue response because of the healing abutments and the platform switching design, and works out wonderfully. Here's another case, and this is the one I'll show you about the nova bone. So this is a site that was extracted and healed. We have 3.4mm of bone in the centermost point position. Same idea. Take that hydrodynamic compression wave, flip it upside down, and we're going to get that same method. So we're going to use the denser burrs. Again, we have to go on about 3mm with the first couple of burrs. And then we start trying to break through the sinus floor. Now you can see I'm going towards that 5mm mark. I've actually passed it by 2mm. Again, 5mm, because I'm at the end of that thick black line. And then I came up with a great trick. One of my friends, Ziv Mazur from Israel, told me about this material, and it's changed the way I've been doing all my internal or crestal sinus grafts. Here you can see we're maximizing our passage through the sinus cavity. We're about 2-3mm past the sinus cavity. And this is just an example, sorry, from Nelson Pinto out of Chile. He's showing you what happens when you drill with the denser burr to the Schneiderian membrane. I'll replay that really quickly.
You had 3.4mm and you drilled a 5.
Yes. Yep. But you can see here, this is the denser burr going on inside here, and it's not ripping the membrane. Because it doesn't have a sharp edge, and because that water is getting up there, it does no damage internally. So they took a nasal scope, put it in through, and you're actually watching what happens to that sinus cavity.
That's awesome.
Yep. He's pretty neat. Then this technique has been fabulous. Using this Nova Bone material, now I have a cartridge type delivery system. I fill that up into the sinus. Watch what happens when I give you the opposite angle. Look how it just finishes lifting up the membrane for me. So the negative about this material is it takes a little bit longer to heal. It's not like allograft. Allograft, you're looking at 3 months, maybe 4 months maximum. With this, you're looking more about like 6 months. But because of the AnyRidge implant, I'm not so worried about the rest of the sinus to complete its healing. If I have 4 or 5mm of bone, I treat it like a 4 or 5mm implant.
Okay.
If I'm-
Hey, Ike, let's stop here for a second because isn't kind of what you're saying. Can you go back and show your drilling video, please, real quick? Sorry, because it's too important to skip over. Yeah.
Yes. So again, we're starting 1 millimeter
So go
short.
ahead,
You see
but see, everybody, wait. But everybody notice the movement that he's using now. His movement is different than what he was using earlier. It's much faster. It's like a pecking motion.
it's a pecking motion. That's
Really
right.
important to understand that. All right, because, and the reason I'm saying this, because depending upon who's using the burrs in this manner, if they're laying on it too hard, you can open up the membrane and you can actually, perforate the membrane. And if you use that Nova bone, now you got a major infection right there, because that's major right there.
Absolutely.
So
that's a very good point.
Okay.
It's a very good point. This pecking motion that we use for these really thin cases where you have only about 3 millimeters of bone.
Right.
When we have 5-6 millimeters of bone, we have much more bone that's going to be auto compacted up into the site. But because we're not here, we're actually engaging the sinus, just like we would on the mica kit. We're actually going in to engage. But instead of using instruments at this point, now we're skipping the instruments and we're going straight towards using a material to finish our lift.
Right.
But you're right. If you engage this stuff in there, because this stuff gets really hard in there,
right,
and it sets like a ball. And if you have a perforation, it's going to block the ostium and it's going to be a big mess. Big mess. So yes, it's a very good point. It's good eye that you caught that too, because sometimes we forget that. So bouncing motion for 99% of these, but when there's short, and you're actually accessing the sinus, more of a pecking motion would be the exact term that I would use. So now we add the bone and then we continue to fill. You can see that I'm on the right hand of the screen. I'm filling and I'm going at 200 RPM in reverse, filling, and I'm not going too far, just barely past the sinus. Because now I'm putting that bone in and it's spinning it around in the sinus, pushing it laterally so that it fills the entire sinus floor. Make sense? Now, if you use allograft, you'd pack and do the same. Pack and do the same.
Which
So
isn't easy to do.
What's that?
It's not easy to do.
It's not as easy to do, and the good news is, and I'm not really allowed to say this, but you're going to have something in your hands very shortly. It was supposed to be out already. That's going to be the same thing from the same company in conjunction with the company that you're working with now. That's going to have an actual product inside instead of a synthetic. So we're going to end up getting faster healing from this, because this is basically one of the main reasons that we want to use it is in the sinus. They realize this is a big selling point. So sinus grafting is like a whole new world. You can see here just how much we lift. We lift a tremendous amount, placing into the sinus. We're going to talk about guided surgery as well. So we have, the same type of approach we can do. We like to make a C guide for this. The C guide is a Versa guide, basically. And the reason that we like to have a C guide is because it lets us see what we're doing. We can get visual inspection of that site. And also because the C guide is open and it allows water to come inside. So you can see that hydrodynamic wave occurring. The good news is that the R2 gate guide already has a window built into it. So if you take the medium sleeves, you can basically do this entire case with the guided kit using just the R2 gate software. So it's a very nice marriage between the two. We're not really advertising that because otherwise doctors are going to start using it incorrectly. But if you have a doc that wants to do just one guide, you could just use the R2 guide that's opened and call it a day. We've been working and experimenting on trying to get other methods of how to incorporate this in, and we probably will have a better solution than just using the R2 guide, like I'll show you a little bit later. But let's take a case like this for a moment. I have a very thin ridge, and if I'm playing the ridge, this is before the MegaGen library was fully in this CareStream software, so I'm using the NE1 implant as an example. And I'm placing the implant in, and I'm trying to place it into the right spot. But basically, if you look at this carefully, I'm going to end up having some sort of a fenestration if I were to drill regular drills. But by taking this narrow ridge and expanding upon it, I'm going to have my implant completely surrounded by bone. So I can do that sandwich technique where I augment. But you can see just that depression of bone at the crestal margin. You can see it very clearly that I'm going to have some type of a concavity there that needs to be grafted.
Yeah.
In the previously, oh, sorry. Let me turn this off a second. Sorry. That's for some reason. I don't know if you heard that, but the music is on and it's very loud. So I got to do that again. So you can see when on these type of cases that we used to expand just under drill in place, we would end up having these fenestrations and we'd end up having to graft and use an iGen membrane. And you could still use an iGen membrane on these cases, but this is a technique that's really much more for advanced docs, having titanium. We don't like to just give a GP that's never used titanium mesh before an iGen membrane and say, here, and you can do this no problem. They usually need your guidance for these types of cases. So having those iGen cases, they're great, they work great, but if not used correctly, they can become a big disaster. So having the denser burrs allows me to avoid having to use this type of a mesh, which I still do use a lot, but the ease of the mesh was great. I could take it out with ease. I get great numbers on Ostel. I restore cases very nicely. So we had great success with that, but today we have the denser burrs to use for our advantage. And so we can take this same type of a case that I just showed you, and I can do this guided, and I can have zero exposure of the implant. I really am completely housed by the actual burr itself. My implant will be completely housed in autogenous bone, in the patient's own bone. And notice again the motion, this up and down motion. And I can then switch to it. This was a earlier R2 gate guides before we actually had R2 gate here. But using the R2 gate kit, I could deliver the implant the same day, which I couldn't do when I was using the iGen. I could torque in a final abutment. We would call this a one abutment, one-time use. We put the abutment in once. We never have to touch it again. Final zirconia abutment because it's R2 gate and I have the timing of my implant set exactly the correct way. I could place a temporary crown on, and I could do some grafting, which I did do some grafting over the buccal, and I closed that up and had excellent healing, did a frenectomy, had really nice healing, and this is 2-year post-op. I didn't make the crowns, the final crowns. He went back to his general dentist. I'm not thrilled with the color of the crowns or the shape of them for that matter, but they're in the mouth and they're healthy and they're good. That's what I do care about, function first. So came out very nice in terms of healing, and I don't have to worry about having to use a titanium mesh in this type of a case, or tacks in a membrane. I could just use regular graft right over the top, sticky bone, and in this case, I'd use some PRF, and that was it. And I have excellent healing 2-year post-op. So we can do the same approach, and for the doctors who are afraid to do the sinus lifts, we can do this in a guided manner. We can control them into the same type of methodology that we just showed you about drilling 1 millimeter short, then passing the burr 1 millimeter past. We could do it fully guided. Oh, sorry, I skipped the case first. That was out of order. I apologize. We have this case of 2 centrals that are hopeless. And this is a case where I went in and you can see that there's 0 bone in this case. Take a look at this, there's no bone. So I'm not gonna be a hero here and try to fill and place an implant at the same time. It just can't be done for me. But I'm gonna extract these teeth and I'm gonna lay a flap, I'm gonna clean it out, and I'm gonna place I'm gonna debride the site, I'm gonna place a membrane with tacks, graft, and come back. One problem, for those of you with the astute eye, I didn't bulk out enough of the membrane. I went too short. So if you look at the upper right of your screen here, this should be further out. You need to over augment. So when I came back, and by the way, I used the tooth grinder, the dentin grinder for this. So I'm using autogenous everything for this case. When I come back and I look at and I compare my before and after, this is my before, and yes, there's significant improvement for an implant at 4.5 months, but it's just enough room for an implant. So if I do extraction drilling at this point, I may be really sacrificing a lot of the hard graft work that I would that I did for this 4.5 months to heal. So by taking this and doing this with the Densiburs, I preserve that bone, and if anything, I expand it out even more. Just keep in mind, and I should have said this earlier, we never want to densify xenograft bone. Always, allograft is okay, autogenous is okay, even synthetic could be okay, as long as it doesn't have hydroxyapatite in it. But xenograft, if you put all xenograft and come back and try to expand xenograft, what ends up happening is you kill all the cells that are helping to feed your graft, and all you're left with is dead cow pieces. So don't try to densify xenograft grafted sites unless they're healed for years. If it's like 2-3 years and they've been healed, no problem. But that's where we see the most failures, with xenograft bone trying to be densified.
What about combo graft material?
Combo of xeno and allo?
Allo, yeah.
Even that I would avoid. I just use straight allograft for these cases because you're going to come back and you have the ability to densify it.
That's a great question because I've never asked this before. How predictable is the Versa in grafted bone?
In allograft bone, fabulous. Fabulous.
Really? Okay.
So 4.5 months, I just have barely enough, but yet I can go ahead and I can treat this case as if it's a healed ridge with nothing to worry about. And I'll show you. I did a guided surgery case. This is like this is 3DDX. I just did a quick drilling with the R2 gate kit. And then I invented these bone expander drills that go on, bone extenders that go with the Densiburs. But I did that same protocol. I drilled all the way, placed the implants in, and then I said, okay, I'm not going to try to take them out because I want to let the bone rest. But I got great osteals. You see, great osteals. I didn't sacrifice any bone. I placed healing caps, and now I'm going to treat this like a healed ridge case. And 6 weeks later, I could come back, and I can now go ahead and start to take my ISQs again. I made those little pieces over there so I can find my tacks if I want to remove my tacks. That was just a guide for that. But here's where I planned, and look at my final CBCT. It's exactly where I was planning it. So I didn't sacrifice any bone whatsoever. I densified my allografted bone, and I ended up coming back and getting wonderful ISQs, 81 and 76. And I was able to finish this case in 8 weeks. 6 weeks, I take my scan, and I deliver my final crowns. And I get very nice results. Not perfect results, because there's a lot of papilla missing. And at 8 weeks, we finished up the case very nicely. So this is a great case, but allograft only. Stay away from the xenograft for if you're looking to densify. That being said, if I'm doing the meat extraction site, if I want to fill the voids with xenograft, nothing wrong with that. So meat extraction, fill it, go ahead and do it. Now, there is one exception, and I don't want to get too confusing, but I know Joel has this on his mind. If I'm doing allograft layering and then xenograft over the top to act as a scaffold, that can be an exception, because I'm never going to really come back. I hope I'm never going to come back and actually densify that xenograft bone. I'll be densifying that allograft bone. But it really has to be layered properly, and you really have to make sure that you're not compressing that xenografted bone. Because the combination of an aggressive implant like the AnyRidge plus the aggressive nature of osteodensification just leads to like Chernobyl inside. I've had the cases really backfire me early on. I didn't know why. And Salah told me, he goes, and he always likes to call you, hey, you stupid. What are you doing? Think about the bone biology, because I have a master's in biology. And he says, you're not using your master's correctly. Think about what you're doing. So the allograft turns over faster, turns into natural bone. I can expand it. Xenograft takes decades to turn over, and I end up killing the blood cells going in that were kind of helping to hold that bone, and end up destroying it all. So that my advice is just to say stay away from xeno, because you don't want the doctors to become adverse to it. And then when they bring it up, oh, but I need it as a space maintainer. Fine, so use it on the outer layer, but keep it away from your sites, okay, when you get pulled into it. Here's another quick case. Dent and ground bone. You guys know how the dent and grinder works. But dentin ground bone at 3 months doesn't look so dense. It looks a little mushy. So I can take this case, and I can actually, this was the case that's supposed to be the guided sinus lift case, and we can do it sleeveless. We don't have to use the C-guide sleeves. We can do the sleeveless and build in stoppers. We know how to do this. It's not rocket science for us since we're using R2 gate. We know how to build shelves in. We don't need to use sleeves. And we're doing the same thing, drilling 1 millimeter in reverse short of the sinus. And then we pass the sinus by 1 millimeter. Once we get, to me, it's the 3545 is the money bird to pass the sinus with. That's the one that I recommend. You can check to make sure you have an intact sinus floor. And this is what you'll see on most of these cases. Once you start drilling, that you'll have like a crystal clear sinus floor when you first engage it. But then as you keep widening out the burrs, you're going to see that instead of having a crystal clear sinus floor, you're going to start to see bone start to impact into that area. So once you get to the 3545, you should feel bone up in that sinus region. You don't want to push too hard, but it should have some fight back against it. It won't be like you're just falling right in, as if you punctured the sinus. So you'll have that autografted bone built in. And this case, it was already at 7 millimeters, so I only need to lift 3. So I did not add any additional graft material. I just simply placed the implant in, put a healing abutment, came back. You can see the sinus, all the autogenous chips that went up into the sinus. Came back, got a great Ostel reading of 80 as my low. I took an impression for those that aren't using intraoral scanning to truly capture the sulcular depth of the implant to the sulcus. To me, the only way to do that is to put flowable composite in and around it, because as soon as you go take an impression, you're filling up your material and all that. It already starts to creep back in. The soft tissue starts to rebound. So you want to capture it. So as soon as I put my transfer in, I flow the flowable composite around it. And even if I take a really lousy impression, like you can see here, that the blue is not uniform anywhere, I've captured my sulcus. So this is a great way to get a good capture of the soft tissue for a soft tissue model for your implants if you're using standard impressions. Then we delivered this case very nicely. Patient was very happy. And you can see that sinus bump that we have on the x-ray. So instead of placing a short implant, I placed a long implant. Yep.
You had 7 millimeters of vertical height, and you drilled a 10 and no bone.
No bone. No bone. And that's a predictable thing you can do every single time. You know, and you can charge for an indirect sinus graft. I don't. I label it and then I credit it back to the patient. I tell them, if I have to use bone, I'm going to charge you for bone. If not, I'm going to not charge you for bone.
So you used a 3545 burn and drilled to 10 millimeters.
That's been pretty much the magic for that. Pretty much the magic is that 3545. That's what happens. You go wider than that and place a wider implant, which I would now. This is a while ago. This is like 5 years ago, 4 or 5 years ago. Today, I'd go wider. I'd place at least a 4.5 with a 3.8 millimeter core. At least. I don't like this implant. I look at it now, it bothers me. But, you know, it's stronger than all the other teeth he has in his mouth, so I think I'll be all right. You can see on the 3-year post-op, I have a brand new sinus floor. He ended up having the same problem on the other side. This one I didn't do guided, but I did a sinus lift. You don't need to see all this, but laminar bone sheets, dentin grinder. I did like a magic surgery all in one. I was able to lift the sinus tremendously, as you can see, using the NovaBone. Again, same methodology, 1 millimeter short with the 3545. I puncture through. I start adding that NovaBone material, and it lifts it up beautifully. Scanned them. This is already, I had a scanner. And then I took, I'm going to skip this part. You guys don't need to see this part. And I made 2 nice screw retained crowns. Patient was very happy. He's about to lose the other teeth in front of that too. You know, he's one of those guys, it's like, until it hurts, he's not taking it out. So we slowly are going to rebuild him into RoboCop. So you can see 2.5 year post-op looking really, really nice on that, with that sinus elevation. Another case, same thing. 6 millimeters on the sinus. Same deal. I can use this guided. Hang on, let me shut off the volume. Sorry. I don't know if you guys can hear that, but it's a very loud noise. You couldn't hear it? I guess it's
No.
only in my AirPods that it comes out. But same deal. I'll mark it. I'm using the C guide type mentality. I'm drilling 1 millimeter short. I'm gonna speed it up for you guys because I know it's getting late.
Who's making the C guides?
What's that?
Who's making the C guides for you?
So I can make it myself, or I'll use Ro can make it, 360 Imaging can make it, 3DDX can make it. There's a whole list of them on the actual Versa site. But
Okay.
you notice here I'm 200 RPM. I just want to show that really quickly again. 200 RPM. I put in the Nova Bone, and I'm 200 RPM without water drilling. So that's also a key. Okay, spreads the bone around, lifts the height, can place the implants in. I made a separate R2 guide for this to deliver the implants. Just so you can see, we're getting down to the black line, right? And the green and the black line, that's the key. Okay, R2 guides rock for this because we have that hex orientation and we have the depth perfectly. So if I wanted to make a final abutment, I could. Not a hero, it's a molar and a second molar. So I'm gonna keep it real. 60s and 70 ostels, these are fine. Wait a couple months and then come back and go ahead and take my scans. But you can see just how much we lifted the sinus. It's lifting it 4 or 5 millimeters with ease with this material. Come back 3 months later. I use a screw retained crown, and I took a final scan post-op, mostly because he now was losing the front tooth. So we were able to take another scan, and you can see a new sinus floor was established again. So it works really well. We can do this and do immediate loading at the same time. We can do a sinus lift, same deal, with the C guide, right? We could take the C guide and the Densiburs. This is using the telestops. They're disposable, which we're not really pushing anymore. Now we're pushing the guided kit, which you can, or you can just still, I think they're still available, the telestops, but we're staying, again, 1 millimeter short of the sinus. I'm going to add in that bone material again. I'm going to drill my drilling, but before I add any material, I'm always checking the sinus floor, making sure, just like I do with every osteotomy. Every osteotomy I drill, I check my floor, always. Something that Joel made me do years ago, and it stuck with me for forever, because one time in one of the courses, somebody was drilling right through, and they actually went through, was right into the nerve, if I wasn't mistaken, or laterally, I can't remember. But
You can
we'll
use that
see this.
mushroom. You can use the mushroom really nicely for that. For the
Mushroom's great.
Yeah.
Mushroom's great for that because it's nice and safe. That's why a lot of these instruments that we have in the mica kit can be very beneficial. Even packing the bone. If you noticed on the other case, I was using the bone packer that has the stopper on it. So
Right.
those things can be very, very helpful. It's not like the mica kit is obsolete. It's just the drills that we're using are different.
Right.
That's really the only difference. We don't need the sinus express burr. But you can see, again, you can see how we're auto-compacting. We're seeing those little flakes of bone go up into the sinus. They're auto-compacting for us already. They create more of a sponge for us, so we're not going to actually hit directly to the sinus. And then again, adding the Nova Bone. This, to me, again, it's a home run. You take this, you put it right in with the composite cartridge gun, squeeze it in, and we just fill it up. And then again, waterless at 200 RPM. And we can compact in that bone. And then we can go ahead and deliver the implant. This is, again, older case, so I'm still using sleeves on this case. But we put the implant in, and I just want to see if there's a, yep, it's in the same position. And I believe 360 Imaging made that guide, just in case you were wondering. I take my ISQ. If my ISQ is good, if I'm looking at like 70s, I'm very happy to load that same day in this case, because he's really pushing me to load and, see the numbers. They're really good numbers. So again, AnyRidge implant, I mean, this thing together with the AnyRidge, just think about it. You're not going to get good ISQs. You're going to get great ISQs. And if I was using a wider implant, like the 4.5, that might get even higher in the 80s. So I have 5-6 millimeters of bone. So I decided I'm going to place a final zirconia abutment the same day. Only problem is my lab's screwed up. So I actually had to take it out and customize it. Look at the shape of that abutment. It looks like a block. It looks like they literally took it out of the zirconia block and just like sent it right to me. So I was trying a new lab, mistake. You know, I like to do a lot of validation to make sure the labs are good. And I think this is one of the labs on McDonald Avenue. They're much better now. I think it's elegant. They do a much better job now. But this, when they sent to me, it was horrible. So actually, while they were taking their x-rays, I drove over to McDonald Avenue. We recustomized it. We fixed the temporary crown. We came back. So in that meanwhile, I had them take a scan to stall the case. Take a scan with a healing abutment on. You can see, look how much of that sinus that we lifted. And that's a tremendous amount of bone to lift, and from a crestal approach. And when you look at it on the CBCT, you can see how it's going laterally. It's not just a dome, it's going laterally and getting towards the edges. So that graft is going to survive. We got some great healing on that.
Vortex energy, right? That's a vortex.
That vortex, that hydrodynamic compression wave. Now you can see we recustomized that abutment to give us the right shape, take advantage of the platform switch. Another great property of this implant is its double curve. You have the bone shift and you have the soft tissue shift. Two separate shifts. That really is unique to this implant. So I did a great job there. Now you can see the final scan. This is, a couple years later. This guy also, he's got, I don't know how many implants in his mouth. Young kid, and we keep getting that. But look coronally, look how much bone you can see that's in that sinus. So we can lift as much as we want. I have cases that lift even longer. But what's next is a question. What are we doing next? And that's about where we're going to wrap this up, is with the new type of guide that we're using, the new stopper system. Now, this system could be used just as a stopper by itself, or can be used guided. If you want to use it guided through the R2 gate kit, just use the medium sleeve. If you use the medium sleeve, you'll notice there's 4 sides. There's a small, a medium, a large, and an extra large, right? And then there on the corners, there's these little plastic pieces. Those plastics represent, again, those small, medium, and large. So they have this plastic piece that's either 1 of 4 of those sizes. Then you have the actual stopper kit. And these come everywhere from 5 millimeters to 15 millimeters. They snap onto the burr very, very easily. As a matter of fact, sometimes they're a little hard to get off. So they stay on very nicely. And we go all the way from 3 millimeters all the way to 15. So we have all the different sizes, all the different lengths. So to do a stopper kit for sinus, right? You pop this out. Doctor says, I'm scared to drill 3 millimeters. I can't see that black line at 3 millimeters. Okay, doc, here's a stopper kit. You can use this. And then we can use this in combination with guides. We can take this over. If we're using the R2 guide, again, the medium sleeve fits perfectly, but you can't get to the wider burrs. Can you get to the 3.5? Yes, you can. You can get to 3.5, no problem. So you can see how we're auto-grafting here, drilling in reverse, 3 millimeters, going wider to the 10 millimeters, not exceeding the floor by 3 millimeters. That's the key on the auto-grafting cases. Okay, on the regular cases, we're putting bone graft. On the auto-grafting cases where we're compacting, we do not want to pass that 3 millimeters past the sinus floor. I'm hoping that maybe we can get an any ridge implant into that animation with Versa. Since we have this collaboration now, we'll look a lot sexier. Just my advice. So here's a case. This will be what I'm going to wrap up with. Using this guide with the stopper, I'm going to do a root membrane technique. So I'm using the root membrane drills. I'm going to find the apex with the guide. Very simple guide to make. 2 millimeter pilot drill. But I use the long drill from the root membrane kit. That's the best drill in the kit because it's super long. I can section the root. I can extract that root. But before I extract it, in this case, I did some drilling with the R2 gate kit just so I can get my spot correctly, and also helps break up that little piece of bone, of tooth, that palatal piece of tooth. So I use the R2 gate drills just to get to length because I find that's easier. Then I switched over to the C guide, and I'm using that same kit in that same pumping motion. I'm using the stoppers. and I'm widening out the site for an immediate extraction, immediate implant placement. Now I'm going a little bit wider. This is, I think, 10 millimeters. Longer, I should say, longer and wider. I'm finished preparing the shield. So again, we have 2 kits for the root membrane. For the socket shield, this is the root membrane kit. It has some great advantages. One of them is guided surgery. Otherwise, I really like the partial extraction therapy kit from Howie. He did a great job with that. And then placed the implant, got into the correct position. It dropped into the nice position. I took it subcrestal, took my ISQ. Let's see what we got. This is with the beacon. It's a little small. I think that said 78. Filled that with NovaBone. And then I took and made a temporary abutment using the fuse abutments. And I luted it to the patient's temporary crown. I made it, turned it into a screw retain, put a little PRF, and voila, we got ourselves a case. 1, 2, 3, no sutures. So easy way to go about using it. You can incorporate into the guided surgery kit very nicely. We can do this in a method where we can get R2 gate and the Versa guide in the same kit. I call this the Versa Total Delivery Guide. And basically it incorporates these little pieces that I developed. And only Road Dental Lab can do this. But you can see how I have these little tiny pieces here that snap in. I redesigned them recently, but you can see how they snap in very nicely. I've redesigned to give more of an R2 gate look with this long type of a span. And so you can deliver the implant through that same guide. It's part of my whole stackable tooth guide system. Instead of taking the guide in and out, I just have to take little pieces in and out like Lego pieces. So we designed this, and now I could deliver the implant through that same guide just using a separate piece. But again, June and I and Korea were in the process before Corona of simplifying this into one guide into the R2 gate software, which we will get done very shortly. You know, that much I can promise you, because I need it for my daily placement myself for all these cases. But so we're working on that. Notice I'm inserting the implant with the MegTorque. It's a great backup emergency implant motor. Something that's totally underrated. We never really look at it. Can really help you out there. You can see my placement is in pretty much close to depth from my vertical depth and from my hex position, the timing of the implant. So I loaded this up. Same day, you can see positioning was excellent. Same day, I decided to put a couple of molars on that we had prefabricated. I bulked out a little more temporary at the connection point because they had sent them unsplitted. So we can do that. What I like to say is that the drill paves the way, but osteodensification makes it stay. So having the combination of getting great primary stability with a great aggressive implant, because sometimes you may not be selling Megagen. You may just be selling the Densiburs, right? For those of you who remember, when we went to Cancun, I did that video about how to break into the doctor's offices, right? So the different stuff that we had were kind of like gateway drugs into Megagen, right? And I played like Bob Marley music, and I showed a joint floating around like marijuana is a gateway drug. Well, Versa can be your new gateway drug into the doctor's offices. It's something that they need, something they've heard about. Sometimes they have misconceptions about it, and they may have heard people have failures with it. So we always want to lead them towards a course. They need to understand the biology of bone. The course that Salah does, that long hands-on course, is invaluable. You can't put a price on that. It's a great course. I've learned so much from him and from that course that changed the way I practice. But he doesn't have something that I have, and that's the EnnyRidge. So he's been waiting 3, 4, 5 months for his implants to heal, when we don't have to do that because we have the actual magic bullet with the EnnyRidge, where we can load faster. So the key points to take away from this is, yes, it's a great burr, it's a great thing, it can be used for any implant. But eventually, once they start using this and saying, wow, I'm getting great results, now can you tell me more about your implant? Oh, sure. Yeah, how long were you waiting for your implant? Oh, yeah, you don't need to wait that long. We have ISQ, the Meg ISQ 1 and 2, and you can use those, you can get your readings, and you can load a heck of a lot faster. And that's where we seal the deal on almost all these cases. So that's my take-home message to you. I hope that makes sense to you. If there's any questions or anything, you guys will have my email address and everything. And we are going to do a course in Florida. We're hoping to do a course in Arizona in January. We just pushed it back to January, so we're going to be doing those. And we do have denser burrs at all those courses, so they'll get to be able to play with them at these courses. It's part of our armamentarium that we use. And I think you'll find most of the doctors will really enjoy using this. It's a great addition to their armamentarium, and it takes away a lot of the need for the other materials that we used to use.
Yeah, this is huge because they're used to already using a drill with a handpiece, so they prefer, quite honestly, the Versa drill. Bottom line.
Absolutely.
Right.
Absolutely. They definitely would rather have total control in their hands with the drill. That's why even our bone expander kits, what was great about them was that it fit the driver, right? So we used to take the driver and be able to expand. Where with other expanders, I have to pick up more stuff, more pieces, more stuff to the assistant to screw up to put in the wrong box, right? And then you're looking for that piece and like, where is it? Where is it? I spent half my surgeries looking for stuff.
Right.
And now we really don't have to worry about that. It's really just a drill kit. And you can add other pieces if you want, but it's pretty much a drill kit that's very versatile.
Cool.
Bottom line is, guys, Versa has a lot of mojo behind it. So for us to not take advantage of it, it's stupid. So we got to take advantage of the momentum that they've created in the industry. And it's huge.
It is huge, and they're growing. It's growing internationally. It's growing. I think Megagen's going to do very well with this internationally, not just in the U.S. And I think that he doesn't have a sales force, and June has really built this up to you guys have the best sales force around. No other guys I'd rather work with. That much I can tell you. And I've been thrilled that we got the right team here. Really highly educated people that have been in the business for a long time and that understand the products. That's the key. And I think that you guys will, once you grab this a little bit more and helps you get into those practices, you're going to sell everything to them. Yeah. I'm waiting for June to bring in chairs because I think that's the next thing you'll be able to sell. He's looking at me like with a stress headache, like enough is enough.
Exactly. He's like, oh, I'm still working. Scott.
Yeah, so I think it is tremendously valuable. A couple of things that just for those that missed the Versa training, like myself, we should be getting that recording any day now. Just waiting for Jessica. And one more thing we're waiting on is Dr. Tal talked about our opportunity. We should be receiving a list of all the AnyRidge Versa users throughout the United States, which we will be able to open the door for us for customers that are not buying from Megagen currently. So that's pretty exciting.
Yeah, that's a lot of doctors.
It's a lot of doctors.
And
so,
when we get booted up with our social media that we're about to, everybody should share this on their Facebook page and with all their friends because everybody's not connected necessarily. So take advantage of the social media stuff that we're going to be coming out with.
I like how you went, as we.
It's true.
That's taking your work home with you seriously.
Yeah. All right. Well, thank you very much. We look forward to the recording, and we'll share this with the folks that weren't able to make it.
Yeah,
and,
I'll send it to you now. And
Okay.
then you want me to just send it to you, and you can send it however you want out to the team. Maybe it's easier to have a link on
Absolutely.
YouTube, and then they can just watch it at their leisure.
Yep. Absolutely. Well, thank you very much.
I'll do a private link to you.
Okay. That'll work.
Thank you for everything, brother.
Yeah,
All
thank you.
right.
Isaac.
Anytime. Sorry I
Thank
went a
you.
little long.
Good
A
night.
lot of info, but
Good
yeah.
night, everyone.
Take care, guys.
Tons of
Thank
info.
you.
Thanks.
Bye.
Bye.